The automatic doors closed in her face at 11:52 p.m. Not the emergency entrance, those stayed open. The physician's entrance, the one that required a badge and a lanyard, and the specific institutional permission that Dr. Yewande Adeyemi had held for 6 years until 72 hours ago, when the lanyard had been placed in a manila envelope by the hospital's HR director, and the badge had been deactivated while she was still in the building. She stood on the sidewalk in the January cold for a moment, her breath visible, her coat not quite warm enough for how long she'd been standing still. She had come back for her parking validation. It was a small thing. It was the kind of small thing that sends a person back to a place they have already left, and she had walked to the physician's entrance without thinking. Because she had walked through that entrance 6,000 times in 6 years, and the body remembers what the mind is still catching up to. The doors did not open. She stood there. Then she turned and walked back toward the main entrance and thought no more about it that night. She did not know, standing on that sidewalk in the January cold, that in 4 hours and 16 minutes she would be standing in the same hospital's cardiac surgical suite, doing the thing that only she, of everyone in a 60-mile radius, knew how to do. Because the patient on that table would be dying, and the only physician in the building with the training to stop it would be the one whose badge had been deactivated 72 hours ago, and whose parking validation was still uncollected in the drawer of her former office on the 4th floor. 7 years before the sidewalk, Yewande Adeyemi arrived at Crestview Regional Medical Center as a fellow in advanced cardiac surgery, and understood within her first week that the institution was running on a combination of genuine clinical talent and deeply embedded structural dysfunction that it had learned, over decades, to treat as normal. She had grown up in Lagos, the daughter of a cardiologist and a civil engineer, in a household where precision was the first language, and where her parents' particular forms of precision, her father's diagnostic, her mother's structural, had combined in her into something that her professors at the University of Lagos Medical School had called, variously, unusual, unsettling, and in one memorable evaluation, the closest thing to surgical instinct I have encountered in 30 years of teaching. She had done her residency in London, her first fellowship in Toronto, and had chosen Crestview for her advanced fellowship because its cardiac program had, under the leadership of its then chief of cardiac surgery, produced outcomes in complex, minimally invasive procedures that were worth being near, regardless of everything else the institution was. The then chief was a man named Dr. Howard Pell, who retired in Yewande's 3rd year at Crestview, and whose departure altered the institution in the specific way that a founding personality's departure always alters what they built. The structure remained, but the logic that had held it in a particular orientation was gone, and the structure began, slowly and then less slowly, to settle into the shape of something different. What replaced Howard Pell in the institutional hierarchy was not a single person, but a committee, and the committee had values that were different from Howard Pell's values, and the most relevant of those differences was that Howard Pell had believed that the primary purpose of a cardiac surgery program was the quality of its surgery, and the committee believed that the primary purpose was the financial performance of its surgery, and that these were, in practice, the same thing, which they were not. Yewande was appointed attending in her 4th year, which was the year Howard Pell left, and the committee's values began to make themselves legible in operational decisions. She noticed the decisions with the attention she brought to all systems, watching how they worked, tracing the patterns, measuring the distance between the stated logic and the operational logic. The stated logic at Crestview's cardiac program was clinical excellence. The operational logic, she came to understand, was a specific kind of clinical excellence that was defined primarily by procedure volume, and secondarily by cases whose complexity and risk profile were calibrated to maintain favorable outcomes metrics without accepting the cases where the risk was highest and the need was greatest. This is what she watched happen, over 2 years, to the patients who arrived at Crestview with the cardiac presentations that required the most demanding surgery. They were referred out, sometimes appropriately. Sometimes because the Case Review Committee, which now included the hospital's chief financial officer as a non-clinical participant, assessed that the case's risk-to-reimbursement ratio was unfavorable. She sat in those committee meetings. She said what she thought. She was heard in the way that institutions hear people they have decided to manage rather than incorporate. She had a particular expertise. It was in a minimally invasive technique for complex aortic valve reconstruction that she had developed and refined across 6 years and approximately 230 procedures. A technique that her outcomes data supported as superior to the conventional open approach in a specific subset of patients, whose anatomy made the standard approach significantly more dangerous. The technique was not widely practiced. It required a specific combination of training and experience that very few surgeons in the country had. Yewande was one of them. Within a 60-mile radius of Crestview Regional, she was the only one. The cases that most needed her technique were the cases the committee was most inclined to refer out. She documented this. She presented the documentation to the cardiac program's medical director, a man named Dr. Craig Emmett, who had arrived 18 months after Howard Pell's departure and who had the specific quality of a man who was excellent at managing up and mediocre at managing the thing itself. He told her the referral decisions were made according to established criteria. She told him the criteria were producing patient harm. He said he appreciated her perspective and would take it into consideration. She had heard this before. She knew what it meant. The conflict, when it arrived in its explicit form, was not about a patient outcome. It was about a publication. Yewande had submitted a paper to the Journal of Thoracic and Cardiovascular Surgery documenting the outcomes of her reconstructive technique over 230 cases, with a comparative analysis against the conventional approach in the same patient population. The paper was, in the assessment of the peer reviewers, significant. The kind of work that would establish the technique as a standard of care consideration, and that would, as a secondary consequence, make visible the specific gap between what Crestview's cardiac program was capable of offering patients and what it was actually offering them. Craig Emmett had asked to review the paper before submission. Yewande had declined on the grounds that her publication rights as a faculty equivalent attending were not subject to administrative pre-approval under her appointment terms. Emmett had taken this to hospital administration. Hospital administration had convened a review. The review had concluded, 6 weeks later, that her appointment was not being renewed. The termination was framed as a programmatic restructuring. The paperwork was clean in the way that institutional paperwork is clean when it has been prepared by people who understand that the paperwork is the record. She was given 72 hours. She cleared her office. She placed the lanyard in the manila envelope. She walked out through the physician's entrance and drove home and sat in her kitchen for an hour with the lights off, and then made herself tea, because her mother had always made tea in the moments that required thinking rather than feeling, and this was a moment that required thinking. The paper had been accepted for publication 3 weeks earlier. It was already in the journal's production queue. The restructuring had not been fast enough to stop it. She had noted this with the particular attention she gave to details that might matter later. Craig Emmett had been chief of the cardiac program for 4 years and had, in those 4 years, built his understanding of the department's capabilities around the staff he could manage and the cases he could plan for. He understood, in the abstract way that administrators understand things they have not examined closely, that Yewande Adeyemi's technique was unusual. He did not understand, in the specific way that the night of January 14th would require him to understand it, what unusual meant in practice. what it meant in the particular practice of a patient arriving in extremis, with a presentation that was not the presentation the program had been calibrated to handle. The patient's name was Gerald Marsh. He was 61 years old, a retired municipal engineer, admitted through the emergency department at 9:47 p.m. with acute aortic dissection complicated by severe aortic stenosis and a calcified valve that had, over the prior decade, developed in a configuration that made the standard surgical approach not merely difficult, but, in the assessment of the two cardiac surgeons on call that night, something none of them were prepared to attempt with confidence. The senior surgeon on call was a man named Dr. Peter Vance, who had 20 years of cardiac surgery experience, and who, by midnight, had been standing at Gerald Marsh's chart for 40 minutes, and had made 3 phone calls to colleagues at other institutions, and had received, from each of them, variations of the same answer. This was a presentation that required either a transfer the patient was unlikely to survive, or a technique that very few surgeons had. Peter Vance knew the technique existed because he had read the abstract of a paper in the Journal of Thoracic and Cardiovascular Surgery that had been published 2 weeks ago. He knew whose technique it was because her name was on the paper. He knew she had worked at this hospital because he had overlapped with her for 14 months before her departure. He looked at Gerald Marsh's chart for another 3 minutes. Then he went to Craig Emmett's home number. Emmett arrived at the hospital at 11:45. He reviewed the chart. He called the 2 other cardiac surgeons with privileges at Crestview. Neither felt the case was within their technical capability at the complexity level it presented. He stood at the nursing station on the cardiac floor and accepted, with the specific quality of a man who has spent 4 years making decisions about risk and reimbursement and is now in the presence of an entirely different category of risk, that the situation was what it was. He asked Peter Vance if he had a number for Yewande Adeyemi. Vance looked at him for a moment. Then he said that she had been terminated 72 hours ago, and her badge had been deactivated, and her hospital access had been removed, and he assumed her contact information had been archived with her personnel file, which would require an HR override to access after hours. Emmett said to get her number. Yewande's phone rang at 4 minutes past midnight. She was awake, because she had been awake since the sidewalk, sitting with her tea and the particular alertness that follows the kind of day that ended with a badge in an envelope and a parking validation still in a drawer. She looked at the number. She did not recognize it. She answered because she answered unknown numbers after midnight, the way physicians answer unknown numbers after midnight, which is immediately and with the assumption that they are needed. The voice was Craig Emmett's. She recognized it in the first 2 words. He told her about Gerald Marsh in the practiced, efficient language of a physician presenting a case. And she listened in the same language, and by the time he finished, she had already assembled the anatomy in her mind, the way the calcification would be distributed, the approach vector, the specific sequence of the technique that she had performed 230 times, and that was, at this moment, the only technical pathway through which Gerald Marsh's situation had a favorable resolution. Emmett said he was asking for her help. She was quiet for a moment, not performing the pause, genuinely in it, measuring the distance between what had happened 72 hours ago and what was on the other end of this phone call, which was a 61-year-old retired engineer in a hospital she could no longer enter through the physician's door, and whose life was moving at the speed of an acute aortic dissection toward a conclusion. She asked about Gerald Marsh's most recent imaging. Emmett read her the measurements. She asked about the valve calcium score. He gave it to her. She asked about the surgical team that would be in the room. He told her. She knew 2 of them. They were good. She said she would be there in 20 minutes. She was there in 17. The main entrance was open. She went through it and to the surgical floor and into the scrub room without stopping, with the specific purposeful motion of someone who has done this 10,000 times and whose body does not require the permission of a badge to remember how. The scrub nurse on duty, a woman named Carol, who had worked with Yewande for 4 of her 6 years at Crestview, looked at her and did not say anything about the badge or the envelope or the 72 hours. She prepared the scrub station. She had known Yewande was coming before she arrived because Peter Vance had told the team, and the team had responded with the focused readiness of people who understood what the night had required and who were grateful it had been answered. Yewande scrubbed and gowned and went into or two, and stood at the table and looked at the imaging one more time, and then looked at Gerald Marsh, who was 61 years old and had spent his career calculating load tolerances and stress distributions, which was its own form of precision, and which had not prepared him for the specific imprecision of a body that had, over a decade, been constructing a crisis he had not known was coming. She thought this briefly. Then she stopped thinking about anything that was not the table. The surgery lasted 4 hours and 8 minutes. It was not the longest she had performed. It was, in terms of the specific technical demands of the valve configuration and the dissection's progression, and the 3 moments where what was required was the accumulated knowledge of 230 previous times she had navigated this exact geometry under this exact category of pressure. It was among the most demanding. She did not experience it as demanding while she was in it, because demanding was not a category that existed for her inside the surgical field. There was only the work and what the work required, and she had trained for years across 2 continents to be the person who could give the work what it required at 4 a.m. in January, with a deactivated badge and a parking validation in a drawer on the 4th floor. She closed at 4:51 a.m. She stepped back from the table. Carol met her eyes over the surgical drape, and the look between them carried the specific weight of years of shared professional language, the kind that does not require words and does not need them. She went to the scrub sink. She stood there longer than necessary with the water running. She was thinking about nothing in particular. She was coming back from the place that surgery took her. The place without edges, back into a world that had edges, and that had shown her several of its sharper ones in the past 72 hours. She dried her hands. She went to the surgical lounge and sat down with a cup of coffee that someone had left on the warmer and that was old enough to be bitter and that she drank anyway. Craig Emmett found her there at 5:15. He sat down across from her in the way of a man who has been rehearsing something and is no longer certain the rehearsal was adequate. He looked like a person who had spent several hours understanding something he had been declining to understand. She did not help him into whatever he was trying to say. She had spent 6 years at this institution, and she was tired in the specific way that follows surgery, and she had earned the right to make him find his own words. He said that Gerald Marsh's family had been updated and the prognosis was favorable. She said she was glad. He said that what had happened, the restructuring, the termination, he said he wanted her to know he was going to recommend a review. She looked at him. She was not angry. Anger was something she had processed in the 72 hours before the phone call and had set aside because anger did not organize itself into the kind of precision she was going to need. What she felt, looking at Craig Emmett at 5:15 in the morning in a surgical lounge that smelled of old coffee and institutional carpet, was the specific tiredness of a person who has been excellent in a place that could not accommodate excellence without reviewing it first, and who has gone ahead and been excellent anyway, because the alternative was Gerald Marsh on a table at 4 in the morning and no one in the building who knew what to do. She said, Gerald Marsh's anatomy was consistent with the patient population in my paper. the technique performed as documented. You should have the or record for your program data. She meant it practically. The or record was data. Data was what changed institutional behavior when testimony did not. She had been trying to give Crestview data for 3 years. Now they had 4 hours and 8 minutes of it in a format they could not restructure away. She stood up. She had a parking validation to collect from her former office on the 4th floor. And then she had a drive home. And then she had the rest of what came next, which she had not yet finished deciding. The paper published in the Journal of Thoracic and Cardiovascular Surgery accumulated, in the weeks following Gerald Marsh's surgery, a secondary layer of attention it would not have received without the case. The cardiac surgery community is not a large community. Cases of the specific complexity of Gerald Marsh's case, resolved at 4 a.m. by the author of the defining paper on the technique used to resolve it, in the hospital that had terminated her 3 days prior. Cases like that travel through a community like that with a speed that the community itself sometimes finds uncomfortable and that it cannot stop. Because the outcomes data is the outcomes data, and the outcomes data is what the community is built to respond to. Yewande received 6 inquiries in the first month. 3 from academic medical centers with cardiac programs that were, by every objective measure, superior in resources and institutional support to Crestview Regional. 2 from hospital systems that were building programs and wanted to build them around someone whose technique was now. In the wake of the paper and the case and the conversation that followed them in every cardiac surgery forum and department grand rounds in the country, the most discussed minimally invasive cardiac approach of the year. 1 from a foundation that funded surgical innovation and wanted to support the technique's dissemination through a training program. She took her time. She had learned over the past years to take time with decisions that would shape the conditions under which she worked. Because the conditions under which she worked were the difference between her technique reaching the patients who needed it and her technique remaining the thing she did despite the institution, rather than with it. She evaluated each inquiry against the question her father had asked at the kitchen table in Lagos, the question he had applied to every structural decision in his career as an engineer. Not what does this make possible today, but what does this make possible for the longest time? She accepted a position at a university medical center whose cardiac program had the infrastructure, the patient volume, and, this was the thing she weighted most heavily, the governance structure to make the technique a program rather than a person. She negotiated protected time to develop the training program. She negotiated co-authorship rights on all research emerging from her methods. She negotiated with the specific precision of someone who had learned exactly what institutional arrangements needed to be written down, because the ones that were not written down did not survive changes in leadership. Every condition that her 6 years at Crestview had taught her needed to be explicit. She started in the spring. Her first week, she performed 3 reconstructive procedures using the technique she had spent 6 years developing. All 3 patients left the hospital. This was the outcome. This was always the outcome she was working toward, in the surgical suite and in the publications and in the negotiations and in the 48 hours of precision that had preceded every decision she had made since the lanyard went into the envelope. The patients left the hospital. The next patients would come. She would be there with the technique and the training and the institutional conditions to use them. And she would do the work, because the work was the thing, and the work was real, and every other element of the story. The sidewalk, the badge, the phone at midnight, the coffee at 5:15, was simply what the work had passed through on its way to the table. Gerald Marsh sent her a note in the 3rd month. It was handwritten, 3 paragraphs, on plain paper. He said he had been told what had happened, that she had come in the middle of the night to a hospital that had let her go, and that she had done it because he needed the surgery and she was the surgeon, and that was the complete logic. He said he had spent his career in a field where the structure either held or it didn't, and where the question of whether it held came down, in the end, to the people who built it, and whether they had built it to hold or built it to look like it held. He said he thought she had built something that held. She read the note twice. She put it in the drawer of her desk at the new hospital. In the office, with the window that faced the courtyard, where the trees were starting to come in, and the light in the morning was the particular quality of early spring light that her mother had always said was the light that made you believe the next thing was possible. She had work to do. She went and did it.